So we are now towards the declaration of the ISNO President's Award for the year 2026. It's my pleasure to announce ISNO President's Award for Outstanding Work in Neurooncology goes to Dr. Manjul Tripathi from PGI Chandigarh. And may I request Dr. Manjul to come on the stage and give a brief presentation of his work. Manjul, it's all yours.
Thank you so much, sir. Thank you, ISNO, for this honor. I think this is more of a responsibility rather than to be used as a badge. So I have been regularly speaking in various conferences, but for this particular talk, I decided to prepare it differently. First of all, I decided not to dye my hair black so that I look seasoned enough and experienced enough worthy of this award. Second, I decided not to show my publications over here because we all working in these fields. Over the course of years, we develop a philosophy of dealing with these disorders. And the philosophy is a dynamic one, which keeps changing with the inputs we get. So whatever the philosophy I could develop here in capacity of a microneurosurgeon and a radiosurgeon, I am going to speak on that part. I am here in a dual capacity, and I think I am a micro-radiosurgeon as well, not only a radiosurgeon. With no particular financial disclosures, principally worked on the gamma knife radiosurgery, but keep cross-talking across different radiosurgery platforms. With around 7,000 patients of gamma knife and 1,600 patients with surgery, we neurosurgeons are the most humble and the most simple people in the hospital across all the streams because we have simple solutions to the most difficult problems, as was the case with Alexander the Great. He was challenged with the Gordian knot. He never tried to open the knot. He just took out his sword and cut the knot. It's very simple. In a similar way, we tried to take out anything which we seemed it's an alien to the brain, but in that pursuit, we had morbidity and mortality to these patients. Much credit goes to Professor Ghazi Asargil. Because of him, for the first time, we could tell that we are going to make some sea change in the natural history of the diseases. And once he was asked with which any other profession he would like to relate himself to, he liked to be called a thief. As a thief enters into the home, steals the things without disturbing the sleep of the members of the home, in a similar way, a neurosurgeon must enter into the brain without disturbing the sanctity of the brain. But many times this is not possible. Blood alone moves the wheels of the history, but in case of neurosurgery, history moved and in the absence of the bloodshed, and that is thanks to Professor Lars Lexell. I would just come with one blue-eyed boy for both surgeons, radiosurgeons. We just heard a heated discussion over here on vestibular schwannomas. Over the course of years, we shifted our gears from life-centric to paresis-centric to facial-centric to hearing-centric to the PEN-QOL and now the quality of life. It's very difficult to change because we all believe in the happy ending of the things. And I go as debater on both the sides, as a surgeon and as a radiosurgeon, when we know that the hearing preservation is 99.9% with radiosurgery, but still we debate. So it's very difficult to change because we have a dogma and we have our own prejudices. Because of our licensing, we get an authority to wish and to decide for others' head. This is credit to Goel sir, because he told me if you take out something with surgery, you cannot put it back. In case of radiosurgery, if you give radiation, you cannot take it back. It's a delicate knife, it's a powerful knife, but once given, it's given. There is no way you can take it back. And whatever the complications you get with surgery, they happen upfront in the perioperative period, and the complications in a wrongly done radiosurgery, they keep compounding over the years like a compound interest, and you pay for that. Your patient pays for that. When the ear hits your brain, you do not remain the same. So very, very careful once you are going to operate because probably the patient would not come out in a similar situation as you took him inside. The psychology of understanding says that the human beings learn things so well that when it becomes a time to unlearn them, it becomes practically impossible because it becomes your second skin, it becomes your philosophy. And over the course of time, you actually keep struggling to explain your philosophy and to prove it again and again. But believe me or not, whatever you have been practicing for the last 3-4 decades, they are going to change someday. We have been frying the brain left, right, and centers just 3 decades earlier. To that time, we have come to the time when we are able to identify the facial nerve at the capsule of the vestibular schwannoma. We are still treating vestibular schwannoma without injuring the facial nerve, without giving any radiation to that. Never ever claim that you have cured somebody for life, because you can never cure. Whatever the understanding you have, probably you would be able to control that disease for the rest of their life. This is one lesson which I got from Professor Goel. Never ever claim. We just had meningioma, we do not know. Because the only constant thing is the most dynamic thing is the pathology here. P.V. Narasimha Rao once told, not taking any action also counts as an action. Many a times, if you are comfortable with the natural history of the disease, a living problem is better than a dead solution. But you should be aware whether you are foolish being patient or you should be patient. And we are bombarded with these data right, left and center. You need to remain very skeptical about it, the way they are presented to you. It might be just 1% mortality with any treatment modality, but for that one unfortunate patient, it would be 100% death. There is no 50% death. So you need to be really aware of it, because one day many of us would be on the other side of the table. The most dynamic science here is the pathology. I operated on this patient 13 times, brain, spine, thinking it's to be a grade 1 meningioma. And then Dr. Vipari Sridhar told me it was never a grade 1 meningioma, it was a malignant solitary fibrous tumor. I realized over this time that glioma is a program made by God to show us how little we are. We keep debating about different treatment modalities and we eventually fail. The only thing which actually changed is the metastasis. And this we need to learn from our colleagues, because WBRT is an exception now and radiosurgery has made a sea change in these patients. They keep coming, living a very healthy life. And you need to learn about IMIFs and MOBAPs and these pathological traits, because they are going to be the deciding factor in the future. Situation is not that good, but it's getting better. As far as radiosurgery is concerned, in the low and middle east countries, especially in the Southeast Asia, only 1/3 of the practicing people have actually some idea about radiosurgery. And that's a very bad situation. The problem is not about the treatment modality or actually the education. The problem is lack of a structured access to these ones. And this is one thing on which we need to work. We and different colleagues, we have been trying to have a protocol, Indian data. We have been publishing them for the Indian scenario for quite a long time. And the situation is gradually getting better. I am happy that I am born in India, because this is one country which does not know any limit in anything. That's why we could practice a frame-based gamma knife radiosurgery, thanks to our radiation oncology colleagues, which welcomed them, and we cross-learned from them how to calculate the BED and the alpha beta. And then we can prove that probably the glomus and the cavernous sinus hemangiomas are no more surgical disease because they melt. And we could generate some indications expanding the horizon of the radiosurgery. For the younger colleagues, I say that listen to the patient's story carefully. Be patient. Do not be in a haste to treat them. Always go in a particular sequence of the history taking and then making a differential diagnosis. Do not try to fit your findings into the radiology and then do it. Your patient must earn the treatment rather than getting as a gift. Otherwise, someday you are going to pay for that gift. Insist on the pathology whenever you have a doubt. If the thing is not going into the natural history, probably you are missing something. There are radiological masqueraders. And if you create a complication, you will definitely do it in your career, publish them, especially with these new treatment modalities. The patients are coming with different expectations, and there are so many things which are influencing their psyche. You need to understand them. You do not need to just extrapolate those treatment modalities on your patient, though they may insist on it. AI is coming in a big way, but we are treating the human beings, not the diseases only, not the radiology. So that AI has to be an empathic AI, professionally empathic AI with SRS. You cannot just bang on them. We have fissures in our understanding, and especially this fissuring is more when you are dealing with the radiosurgery in the genetic and the epigenetic milieu of these patients. And this science is gradually evolving, so be open to these challenges and these new suggestions. I say that I have seen the slides a couple of times earlier. These two fingers never meet. The God has extended the fingers completely, but Adam has flexed the distal phalanx. And that distal flexion is actually the free will. And this free will is with the current generation of the neurosurgeons and the radiation oncologists. So once my neurosurgeons ask, why should I learn the radiosurgery, I show them this picture. When my radiation oncologist and other colleagues ask, why should we learn your philosophy, I show them this picture. Because we need to cross-learn from each other to make the best of these two treatment modalities. Because neurosurgical progress or lack thereof is based on the things that we can measure rather than the things that we should measure. The yardsticks are different for us and for our patients. They should meet. In the end, I say that SRS is not a poor surgeon's surgery. Neurosurgery demands micro SRS because you are dealing with the most unforgiving organ of the body. SRS is offering a large scope of effects from the low dose modulation to the high dose lesioning effect, and the neurosurgeon's expertise is especially critical in this field and must remain central in the interest of patients, irrespective of the SRS platform, whatever is in your hospital. Extremely proud of my team at PGI Chandigarh, with which we have been doing it for quite a long time. This all is work because of them, and I am so happy that many of my teachers, Professor Goel, Professor Suri, Professor Pathak, my family, PGI Radiotherapy Department, thank you so much for this honor.
Thank you, Dr. Manjul. May I now request Dr. Pathak to felicitate Dr. Manjul with the plaque and Dr. Goel with a check of rupees 10,000 for winning this award. Big round of applause for Manjul once again. So.
It's a proud privilege for me to present something to Manjul. So this is the day I was looking for and got it today.
The ISNO President's Award for Best Clinician Researcher, so you have to still be on the stage. The